Invite the next speaker, Dr. Sachin Mahuli. He heads the Netradarshan Eye Hospitals, Belgaum. So he is also an excellent surgeon with a great academic record. And I call him upon to speak on role of B-scan and UBM in diabetic retinopathy. Over to you, Sachin. Yeah, screen is visible. You can go ahead with your presentation.
Yeah, thank you. At the outset, I'd like to thank Scientific Committee, AIOS, and Sunil for having this wonderful IC. Just a moment, I'll just put it on. Okay.
Just play button, push the play button, this is the full screen.
So we'll go ahead with the talk. Like, my talk today will be on the role of B-scan and UBM in DR. B-scan is a very well-known, age-old, investigation which we advise for diabetic retinopathy cases, especially when there is a lot of media opacity and vitreous hemorrhage and other indications. We'll go one by one. How does B-scan help us in clinical scenario when we see a case of diabetic retinopathy, especially when there is a media opacity? So it helps us to diagnose. It is very useful in as a diagnostic tool. It also helps us to prognosticate the case and definitely helps in surgical planning. Now we'll go one by one how the B-scan would be used in cases of diabetic retinopathy. The most common indication would be a vitreous hemorrhage. In the case of proliferative diabetic retinopathy, to understand the status of the retina. Then the other indications would be like total cataract or a dense cataract. Even a dense asteroids would be indicated, a thick PCO. In some cases of NVG, wherein there is a corneal edema and you are unable to assess the posterior pole and the retinal status. In some cases of combined retinal detachment and TRDs, you would like to do, especially associated with vitreous hemorrhage, you'd like to do a B-scan to understand the extent of the retinal detachment. In cases of post-operative, post-surgical, like post-vitrectomy, B-scan would be very handy to understand whether it is a diffuse hemorrhage following the surgery or it is a retinal detachment underlying following along with the vitreous hemorrhage. In certain cases of post-operative hypertony, to understand if there are choroidals or if there is some other pathology inside, it would be a handy tool to see. In cases of vitreous hemorrhage, B-scan can be used to understand the status of the retina, status of the PVD, and if there is associated TRD and combined retinal detachment. B-scan, the features of B-scan in a fresh or acute hemorrhage would be the echoes will be scattered and less echogenic with a good after movement. As the time passes by, the vitreous hemorrhage gets more thicker and denser and causing it more echogenic, more organized, more membranous, with reduced mobility. And you can also see a blood-lined PVDs in such cases. Sorry. B-scan also demonstrates as the status of PVD, whether the PVD is complete or incomplete. It also helps us understand whether the echoes are more of intragel or subhyaloid echoes. Basically, why this is important for us is to understand like the extent of vitreous hemorrhage when we plan a surgery. Now, this is a case wherein you can see predominantly intragel echoes and a blood layer PVD with an incomplete PVD. Basically, it is attached to the posterior pole, and this is how it helps us understand the disease better and helps us to plan the surgeries. This is a case of massive subhyaloid hemorrhage with incomplete PVD, wherein there is a peripapillary membrane also, which we can see. So these are very, very important for us to make a surgical decision as to when the surgery has to be taken, because this type of massive subhyaloid hemorrhage is unlikely to get absorbed on its own, and we may have to plan surgery. Vitreous hemorrhage along with TRDs is a very important finding which we see in day-to-day practice, and which definitely helps us decide whether to take him up for surgery or not. This is a case wherein you can see a picture wherein there's a TRD with the focal attachment to the incomplete PVD. There are plenty of subhyaloid and intraretinal echoes. We should also understand that there could be multiple membranes, like especially in cases of vitreosis. wherein you can see a multi-layer membrane. All of them would have a good after movement, and it should be differentiated from a retinal detachment. Coming to the tractional retinal detachments, detachments on B scan would be picked up and located, and basically we can understand whether the TRDs are involving the macula or not, or it's extramacular. It could be a focal detachment, it could be multiple TRDs, or it could be a broad TRD involving the posterior pole, depending on the disease severity. Basically, what we need to understand on a B scan when there's a TRD is how is the vitreous attached to it, whether there's a focal attachment or whether there's a broad attachment, which will again help us plan during surgery. If there are subretinal echoes in the TRD, that means there is a subretinal, probably a subretinal bleed or a long-standing TRD with a subretinal exudation. If there's a subretinal bleed, it indicates the severity of the disease as to how much the vitreous hemorrhage and extent of hemorrhage which is occurring. These are the cases of TRDs again, where you can see a focal attachment and a broad attachment in earlier two cases, and there's a hammock-like TRD wherein the complexity of the membrane can be understood by the B scan. TRD involving the macula is definitely an indication. When there's a vitreous hemorrhage, B scan definitely helps us prognosticate this case and help us to take up for surgery. Combined retinal detachments associated with vitreous hemorrhage, you should definitely like to do a B scan and find out what is the extent of TRD and how are the vitreous attachment to the TRD. Specifically, in cases where we cannot see the disc or the posterior pole, whether a combined retinal detachment with a closed funnel or extensive pre-retinal proliferation would definitely help us severity of the disease. So as I said earlier, how does it help us prognosticate when there's a dense vitreous hemorrhage with no PVD? So surgery is going to be difficult in such cases. So with the dense vitreous hemorrhage, we should tell the patient about the prognosis based on these findings. So if there's extensive pre-retinal fibroscular proliferation, that is very broad attachments on a B scan with vitreous hemorrhage, causing a large area of TRD or a combined retinal detachment, would definitely be a bad prognostic sign. Taut or a broad attachment, as I said, anterior hyaloid proliferation, if you note on a B scan, especially in the area of just behind the lens or just in the anterior hyaloid, would definitely be a bad prognostic sign. Underlying, there could be a complete CRD or a extensive membrane formation. Subretinal echoes and bands are again an indication of a long-standing TRD or a CRD would carry a bad prognostic sign. Extension of CRD and a closed funnel configuration on a B scan would be again a bad prognostic sign. A thin atrophic retinal echo, thin membrane-like echo, when you see it would also give us a prognostic indicator that whether the surgery would help the patient or not. How does the B scan help in surgical planning? When there is a dense cataract and other eye has a diabetic retinopathy and you would like to plan a surgery, especially a combined surgery would be required, B scan is definitely handy, and you can see if there are if the case has a vitreous hemorrhage or a TRD or a combined RD. It helps us understand the vitreous attachment to the retina space. Basically, when you plan a surgery where you want to truncate the cone during vitrectomy, especially we'll understand whether there's a focal attachment or a broad attachment. Based on this, you can plan your intraocular tamponades. If there is a combined detachment, definitely you would like to use an oil, or if there is just an TRD in the posterior pole with a focal attachment, or gas would do. Or if you are anticipating a break during the membrane dissection with the extent of pre-retinal proliferation, and you can understand where the PVD is occurring and where you can get the plane for your membrane dissection. Asteroid hyalosis is a definitive differential diagnosis in diabetic patients, wherein this also presents with a lot of intraocular echoes. The differentiating point would be there would be a clear zone in front of the retina and the vitreous, optically clear zone. So this would differentiate it from a vitreous hemorrhage, and it's definitely useful in cases of PDR, especially when you cannot assess the retina with a dense cataract. Coming lastly, very quickly, the role of UBM in DR is limited, but very, very specific and useful in cases of, mostly in cases of recurrent postoperative hemorrhages. in cases of hypertony and in some cases of neovascular glaucoma. There's a wonderful study which is published in Ophthalmology 2000 by Dr. Munna Bende et al., which actually analyzed the site of pars plana vitrectomy area, especially the sclerotomy area, wherein they classified it into eight types. They did a UBM after 6 to 8 weeks following surgery. They classified it as a well-healed gape or a plaque. I'll just take 30 seconds, okay? A gape, plaque, or vitreous incarceration, whether there's a fibrovascular proliferation at the site of sclerotomy, and intrahalar proliferation was also seen. So all these will tell us the prognosis of the case, why there is a recurrent vitreous hemorrhage, and how do we manage these cases. These are the pictures which shows wound gape and the fibrovascular ingrowth. The down picture here, you can see the fibrovascular growth at the intrahalar phase. Cases with, as I said, recurrent vitreous hemorrhage and no FVP at the sclerotomy seen on UVM did well later when the patients were taken up for a resurgery. In cases where there was a ciliary body detachment like this, if you see the ciliary body detachment with a lot of membrane echoes around the pars plana region, would definitely be a bad prognostic indicator. Okay, I'd like to finish my discussion on this, and thank you very much for your patient hearing.
Thank you, Sachin, for this brief overview of ultrasound and UBM.